Welcome all to episode 3 of our season 2 Sparked podcast. We'll be discussing where Sparked fits in with allied health. What are the challenges? Is there going to be a payoff for the clinicians and patients who use the services? My guest today, Bronwyn Morris-Donovan. Bronwyn's CEO of Allied Health Professionals Australia. She's an experienced consultant with expertise in primary health sector advocacy and policy, and a self-described non-expert in digital health, but nonetheless has terrific insights on the sector. And Kath Feeley, she's Chief Allied Health Information Officer at the 4 Parkville Precinct Hospitals in Melbourne. Kath's passionate about using technology and data to evaluate and improve clinical service delivery and patient outcomes. All right, diving in on questions, and just a small and simple one to begin with. What's the importance of shared care and chronic condition management? I'll go to you, Bronwyn, first, if that's all right.
Thanks, Brett. So I do want to preface up front that my perspective is from the private or the primary allied health sector. So for me, I'm talking about the provision of care outside of the hospital setting that's funded via aged care, NDIS, MBS, private health insurance and compensable schemes. Already you can see that we've got multiple data silos happening in our primary environment. With 1 in 2 people having a chronic condition, and the majority of that care happens in the primary healthcare setting. So allied health, being the second largest health workforce, is a significant contributor to the care and management of people with chronic conditions. And the literature tells us that a multidisciplinary approach to chronic disease management does result in better health outcomes for the individual. But that's where we fall over. So we have the language and we have the knowledge. But while we want allied health professionals and we want GPs to work in these multi-D teams, the clinical data that's generated by allied health professionals sits in these data silos. As a sector, we don't use consistent data terminology yet. So data standardisation is a piece of work that we've now embarked on, and our clinical information systems don't talk to each other. So even if we had data standardisation, we can't participate in that data exchange. Then we have this situation where allied health providers, so they can't share the clinical data that they produce, but they also can't see or access the clinical data that other healthcare providers produce. So we're working in a multi-D team, but we're in this quite isolated vacuum. So we literally have thousands of allied health providers in the primary care setting sitting on these quite data-rich data silos, but we can't get to them. The other point that I wanted to just briefly comment on is about chronic disease and sort of chronic disease management plans. If we play it through, we've got a GP in collaboration with the patient or the client, and they're generating a chronic disease management plan together. And then as a part of that plan, the patient can access 5 subsidised allied health services per calendar year. If we briefly look at a patient with diabetes, as part of that care plan, they might access a podiatrist, a credentialed diabetes educator and a dietitian. We now have a little care team of 4 individual professions. None of them can input into a shared summary to improve their decision-making at the point of care. Instead, we've got 1 care team and we've got 4 separate data silos happening. We're missing out on these rich data opportunities. And from our perspective, and we are, as Brett said, we are very new to this digital environment, we're looking at it from a policy lens and thinking, hang on, we want to be a part of this dialogue. We want to be a part of the multi-D team, but digital interoperability is the pathway by which we're going to be able to participate fully in these multi-D teams.
So fair to say, Bron, that there's a deep interest in the data and amongst these thousands of allied health professionals, a recognition of the profound value of that data, but a great frustration in not being able to access it for that single source of truth and that consolidated care plan, care pathway for the patients you're looking after.
Absolutely. And historically, we are very focused on the flow of data from the hospital setting to the general practice setting, and necessarily, but we also need to focus on the flow of data in both directions, from general practice out into allied health, and then from allied health back into the general practice. So I guess with that policy lens, we look at the strengthening Medicare reforms and we look at the language towards multidisciplinary care, and it sounds good. But without that digital connectivity, I can't see how those allied health providers can genuinely participate in the multi-D team if we're not sharing the clinical data that we produce.
Kath, you're working on this enabling infrastructure and environment. Tell me your perspective on the importance of shared care and chronic disease management as it relates to that environment.
The way that we've started to think about it is that the care needs to be patient-centred, particularly in this chronic disease population, and that it's able to be seamless care that patients can easily navigate. At the moment, as Bron was talking about, I might have some information that sits in a GP system. I've got some information that might sit on paper or in an electronic system in different allied health teams. And it's thinking, Bron, around how have we got to the point where other craft groups have actually moved further along in this space, thinking about shared data, common data sets, and allied health has been left behind, so to say. But we just have such a broad breadth of professions that sit under this one umbrella, and that partly has made it challenging. This morning I was meeting with one of my colleagues and friend from New South Wales, but I was saying, right, how many allied health professions does New South Wales recognise? And they recognise 35 separate allied health professions. In Victoria, we recognise 23 allied health professions. We don't even have some of those base national standardised, even in like what is allied health. So I think that has been part of the issue with us getting on board to think about how we can do this in a better way. But for us, if there's information that's important for a patient's care, everyone who needs it should be able to access that information. And how we do that is, I'm hoping, and this has been quite positive, working with Sparked and particularly just starting with the patient summary, having that opportunity. So if I find something out and I'm a physio working in the community that the patient hasn't told anyone else, but I think it's important, and everyone else needs to know that, to be able to have the opportunity to input that, there's decreased duplication for the patient, and that information then provides additional knowledge for everyone who's caring for the patient. That's how we're trying to think about it. Moving a little bit away from who owns the data is also a real challenge. The important part is that we all want to work together to improve the care of the patient that we're seeing. But it's important to make sure that all aspects, including if all of the allied health professionals might be involved, but how we get that information included is important. And coming from a public health perspective, we see that maintenance of wellness sits in the community. So if someone has an acute illness, yes, they come through to us. Some of our hospitals have relatively good information sharing within the hospital, but we're in the same circumstance. Being able to then send it on to our colleagues who works in the community, it'll probably come as a PDF and not even have standardised information that is necessarily relevant for you coming out to the community. So there's definitely a lot of opportunities for us in this space.
So recognising that you are behind the eight ball in terms of systems or those dynamic shared care arrangements, what do you think the opportunity is to contribute here? How can you be involved and how would you like to be involved?
The important part is understanding that allied health needs to be in the picture, which has been great, and now getting on board. I met recently with our National Chief Allied Health Officer, Anita Hobson-Powell, just to talk about having sort of a larger reference group that we have available that we can, if Spark needs some feedback from an allied health perspective nationally, let's have a group that we have available with clinicians, informaticians, experts from the area. I think that's a great opportunity. Even just coming together and starting talking about it across the states is a good opportunity. We probably do that a bit. Some states are doing better than others, but how do we bring it all together? Because in essence, we're going to need a standardised approach for allied health. And there's certain aspects that we could focus on which are actually pretty standard. So even if you're one of the 35 areas, there's some standard things that we do. So we receive referrals. We send off discharge summaries. Are there some smaller bites that we can start looking at Otherwise, it will feel a bit overwhelming because there's a lot.
Who doesn't need to refer back to primary care? Who doesn't need to have information available for the larger family member, carer support network to know what's going on? You're absolutely right. Bron, you sound like you're keen to be part of the opportunity to contribute. What does that look like for you?
Yeah, we are, and it's a good question. I want to go back to a comment that you made, Kath, about the diversity of the different professions. In part, that's what is so difficult about allied health for others outside of the sector to engage in, because it's almost like, where do we start? It is so big and it is so diverse, and that you do need to chunk it down and group, say, musculoskeletal professions together and go, you do your data terminology work together. We don't need 5 different musk professions coming up with 5 different versions. We need you to sit down together. And that convening function is a large part of our role. The first comment probably is to say that, yes, we are a long way behind, and there are a whole raft of reasons for that, which we probably don't need to get into. But the benefit of that is that we can learn from what's happened in the specialist and the general practice sector to accelerate allied health integration. I feel like we're forensically looking at what's gone well and what hasn't in those 2 sectors. So we don't just do a complete repeat of those 2, because there are actual real differences to the allied health sector and commonalities. So I've got 4 threads of work that I briefly want to touch on. The first is education. We haven't systematically pushed education out into the primary allied health sector, and that is digital education. But we need to do that in a very sequenced way. And one very quick example of that is most allied health professions in the primary care sector do not know how to access an HPII, and virtually none of them have got an HPII. So we're working with Services Australia to create a legislative amendment to enable this bulk allocation of HPII to self-regulating allied health professionals. And that is the very first piece of work and education that we need to roll out to the sector. So there's no point leapfrogging that and rolling out education about the My Health record if they can't actually get into the My Health record because they don't have an HPII. So we do spend a lot of time working with our key stakeholders to say we are different, and yes, there's a lot of similarities, but we have to respect the fact that we're so far behind. You can't just push in education that the sector is not ready for. We need to go back to the beginning and start at the start. And that looks like fundamental security and privacy education, for example, before we start pushing product utilisation. My other second quick one is mapping. I think you touched on, Kath. We don't have any systematic standardised way of capturing clinical data in allied health, and that is amplified in the primary care setting. That's where our intersection with Sparked has come in. We looked at that piece of work and went, you know what, this is an opportunity for us to come to the table now rather than waiting for all this good work to be done and then we try and join the party. That was the motivation behind ARPA joining Spark. The third piece is about industry, and that is in primary allied health, we're aware of 39 different clinical information systems in use. And of that 39, the 5 most commonly used products, which sweep up 65% of our market, none of them are conformant with the My Health record. So we have a lot of work to do with industry to even get products into the market that are conformant with the My Health record. And then my fourth and final piece is when we do think about those digital products like the My Health record, they're not currently fit for purpose for allied health clinical data. So we've got to build that conformance, but we also need to make some amendments to make sure that they are suitable to house the clinical data that allied health professionals produce. And without that piece of work, I don't think we can reasonably expect allied health providers to jump on board, because if they get in and find that there's nowhere for them to put their clinical data, I think it's very off-putting and it's not appealing, and we need to make it fit for purpose like we have for the general practice and the specialist workforce.
Super, thank you. And for our listeners, I think they'll all know HPII, but for our listeners who may not know, it's the healthcare provider identifier individual. And so the ability to make those matches between the service provider and the clinical records that are held with the patient.
And now it's time for a fun fact from Kate.
Sparked is making its way around Australia to ensure specifications are fit for purpose for all Australians. We're looking forward to visiting the remaining two, ACT and Tasmania. Award goes to Adelaide for the biggest crowd to date.
Kath, can I go to a question on the public and private system? Can we get into some of the differences in terms of validation and value appreciation?
I've worked many years as a physio primarily, but it's all been in public health, both here and in the NHS. As we've moved more into this digital space, I think we've got more and more allied health staff who are now saying, right, finally, yay, this is an area that I can be in and I feel like I can do some contribution. We're lucky that has actually been recognised in some public health services that there will be allied health information officers or chief allied health information officers who can start thinking about what is the importance of data collection and data exchange. Originally, Allied Health put a lot of effort from a public health perspective into a data set which was more around how we spent our time. It is a beautiful data set and it is beautifully created, but the value, I'm not of the era that worked on that, and everyone's very proud of that work. But the value that comes from that is a little bit like the value that we see in some of the national registers from an allied health perspective. For example, in the stroke register, the questions are quite detailed from a medical perspective. Did someone receive, I'm going to get that word wrong, thromboembolic medication? Yep, or not. And the questions are, from an allied health perspective is, did a physio see the person? Yes or no?
Yeah.
And it's the same with accounts that we've been doing for a long time. It's, did we see a person? Yes or no? But what's missing is that value proposition. So sure, we saw someone, and even in the stroke register, we can say 70% of people saw a physio and 100% of people saw a speech pathologist, for example. But there's no so what at the end of that. And that's partly our issue because we didn't have those standardised data sets to say, well, while you're developing a stroke register, in speech, could you please also add this swallowing assessment tool, which is an outcome measure that we'd love to just plug in. And we'd now have 10 years of data on every patient in Australia who had a stroke. And it's not just this was our outcome measures sort of pre and post, but we're also missing that intervention piece. I think one of the opportunities that we're looking at is going to start having a standardised data set that we at least use across the 4 organisations that I work in. New South Wales has done a good job from more of an intervention perspective. They've sort of got the what we did, but they're still missing the value part, like what change did it make? Hopefully we'll publish this, and we're doing it as an implementation science project as well, because Queensland Health have this amazing huge data set in this space but have struggled to implement. So what we're doing is, while we're developing a data set, is looking at how do we implement it, what's the way to get staff to use it, how do we get the buy-in, and how do we then get them to understand the importance of putting the data in the spot where it needs to be. We can use that data in the future. This is a new journey for us across public health, and it's just not a journey at all, I think, that in the private space certainly is not happening on a bigger perspective. But what we're trying to do with the work, particularly that we do, because there's barely any research out there from an allied health informatics perspective. If you sort of do a search in that space, you'll get about 4 articles, some from pharmacy, but maybe 4 other articles in total. We're trying to fill that space a bit from a research perspective so that we've got some evidence behind what we're doing, whether it works well or it doesn't work well. So that's what I think is important.
I remember the stroke register from some years ago, so I think it's been around a while. And I have to say, my reflections in my clinical years were that allied health was all too often thought of, what's the thing to fill the little clinical need gap that exists here, rather than the idea of an integrated clinical care approach and a holistic management that is genuinely patient-centred. I guess it goes, Bron, to that issue again of the opportunity to contribute, to say this is valuable, this is not, this is how I would capture it, this is what I would capture, and this is why it is of use in a clinical setting.
Absolutely. There is also partly a responsibility on the primary allied health sector who produce volumes of clinical data to say not all of it does need to go into a patient summary. And so we're bringing, you mentioned 35, so we're bringing 28 professions to the table. And next week, in collaboration with the CSIRO, we have our first 2-day face-to-face workshop with a focus or a lens on chronic disease management to go, okay, if we divide this 28 into subgroups, say musculoskeletal is an easy subgroup for us, can you work together over the 2 days and then take the work away to begin to look at the document types and the data types that you produce and the clinical terms that you produce in a musculoskeletal world, so we can work towards essentially mapping those clinical terms with a Snap to SNOMED tool. And Kath, you mentioned, data informaticians. We don't have any in primary allied health. So if there's any data informatician with a primary allied health hat on listening to this, please find us, because myself and my colleague Jackie have been on this rapid learning curve over the last 2 years because we see opportunity, but to be a participant in that opportunity, we have to bring a representative from these 28 professions to the table, and we have to teach them together how to go away and do this mapping work. And that's hard for us because it's a skill set that none of us have. So better integration with colleagues like you, Kath, and your other colleagues to go, well, you're ahead of where we are. And I think that's been great learning for us as well. But, I think I'd like to say that in the next 5 to 10 years, we do have primary care, allied health data informaticians, and we have real leaders in that sector, much like we're now seeing in the public sector.
It has to start with sitting around the table for 2 days, doesn't it? If you're going to get that standardised nomenclature and an understanding of what's needed and an agreement on it, that's just lots of chat, lots of useful chat.
Yes, and I think that we've had 5 years of a lot of chat with not a lot of action. And so a very discrete example of that is that there has been some work done in the aged care setting about allied health data terminology. And it took the sector a year and it hasn't gone anywhere. And so I think that we have a responsibility to say, if we do want you to come to the table for 6 months worth of work, we will take this somewhere for you and you will see some benefit from the contribution that you've put in. Because I feel like we do take a lot and we don't put a lot back in. And particularly in this data environment or this digital environment, they need to see some benefit for coming to the table off their bat. We don't fund their time and we need all the different professions to engage in order for this to be successful. So I do think that collectively we have a responsibility to say we recognise the importance of your clinical data and we will put it into a product that you can see at the other end.
That's the raison d'etre of Sparked as an accelerator. Kath, what might success look like for you in terms of the Sparked program?
One of the things we sometimes struggle with in public health when bringing in a large EMR system, a lot of them are American-based. And so the way allied health works in America is so different to how allied health works in Australia. I've just had 4 years of arguing that allied health work as autonomous clinicians in Australia in a way that someone can be referred straight to an allied health professional. They can do an assessment, make a diagnosis. Some of them can order tests. Some of them can prescribe medication. And it has taken a long time. But we're lucky the people that are out here and living in Australia are starting to see that it's different. But for us, I've now implemented 2 EMRs. If I had even part of a data set that I can just say, this is what we need, start here, build this, and then we can add our bits on top. I've been recently working with New South Wales Health. We have spent a long time getting things fairly good, even just those standard, how to do a referral, how to send a discharge summary, the easy part that is standard across the professions. And then just saying we have worked really hard to get to this point. We are really happy to share. Learn from what we've done. Don't start right back at the start again. And then if we've got that additional support through some of the data sets that comes out with Spark to be able to just hand over to say, this is just minimum standard that we need, that will also over time allow us to then start capturing that intervention value. Then when we're looking at bigger data sets, we can actually start to investigate more around what we do without having to run a research project where you have to capture these 20 things. But if we're just getting things captured every day as part of standard care, it's really going to help us to think about our populations that we're working with as well. One of the challenges for us, though, is we did a capability self-evaluation of our staff from a digital health perspective around data and informatics. And I was like, yeah, like people are going to be amazing. And then when we got the results back, the area that people knew the least in was around basics, data quality, data integrity, the things that we talk about all the time, put good data in, get good results out. But that's not even a baseline for our staff. So that upskilling will sit somehow beside the other work that's happening. I think there's going to have to be a large change in culture, thinking about, I don't own the data about my patient. My patient should own that data, and then they're free to take that data wherever they need to go. And that is actually a real shift. We've been sharing notes. We have a patient portal. About 70% of our outpatient notes, once you see an outpatient, goes to the portal. If the patient have a portal, they can read their whole outpatient notes. It took us a while to get clinicians across from outpatients. We've now tried to start doing that from an inpatient perspective. And again, the barriers are coming up. It's just such a culture change. Why would I share my inpatient notes about a patient with a patient? Well, that's because that's their information. So let's share their data. We can have a really great data set, and then it's around that cultural shift.
Are you saying the physician is not at the centre of the universe, Kath, that the patient might really be at the centre of the universe?
It's crazy, isn't it?
It is. It should not be crazy. It seems like it's a crazy cultural shift that we're going through, but there's a lot of talk about that being the starting point. And Graham Grieve in particular talks about not the data following the patient, but the data being with the patient the whole time. It should be on the phone or it should be at one's fingertips wherever one might be encountering care. I think that's the vision we'd like to see manifest.
I think so too. We did a survey. We had about 1,300 patients give us feedback on using technology in their health. And we had 70% said their health is better from using technology, and 86% said they are more connected with their own healthcare journey than before they were using technology. And so, again, we're in the situation where our patients or consumers haven't been expecting this yet, but I think it's not going to take long where the drive from our consumers and their expectations may help with that culture shift as well.
And Bron, Spark Success, what does it look like for you?
I'm excited by all of your comments, Kath. For me, success actually looks like building a community of primary healthcare digital champions. And I feel like that's a really throwaway line, like digital champions. I've turned into a marketing person and we're spruiking digital, and no one is quite as passionate as Jackie and I. Part of our job is to actually bring those 28 professions, which means our associations who have a majority of their members working in the primary care sector, to this party to say, if you've got, say, PROMs and PREMs down the track, a requirement to collect PROMs and PREMs within an MBS, chronic disease management item, then the very first starting point is this. We don't start upstream with PROMs and PREMs, we start all the way back here. So we have found this sparked community exceptionally welcoming. And often, I think when you talk about culture, my interpretation of culture is that we spend a lot of time demonstrating the value of allied health and why we actually need to be at the table. Whereas we got an open door, yep, if you want to come along. And that sort of started our engagement with this work. And that doesn't normally happen for us. I'd like to think in the next couple of years, success really does look like finding those practicing clinicians who are out there and are part of that sort of day-to-day on-the-ground feedback that we really need. That's number one. Number two, in terms of success, is through that policy lens, and it relates to culture. If we have got data sets, we're not then constantly trying to stand up a research project to answer a question that is asked of us, usually from the Commonwealth Department of Health and Ageing, that relates to cost effectiveness, value, recognition, why we need to be at the table. It neatly ties that up with a bow, and we can all move along further down the pathway and actually start talking about how do we measure value? How do we embed PROMs and PREMs into the system? And the answer to that is going to be much easier if we've already got minimum standardised data sets into the system. That's the long-term play, if you like, for why allied health actually needs to be a part of that sparked community right now. And then the third is that has an enormous ripple effect in terms of the decisions made at point of care with our clients and our consumers. Noting that for us in our primary allied health world, in any given day, we might have a consumer who's a participant of the NDIS. We might have someone with a MUSC problem funded through private health insurance, compensable schemes. We've got this really quite diverse client consumer group, but we need to create some standardisation amongst all of those consumer types in order for us to embed proms and prems into the system.
From a research perspective, it sounds like a whole world can open up whereby, as you say, you don't need to do separate and individualised intensive data capture if you've got a standardised set that you can interrogate that actually has quality at its foundation.
Absolutely. It's really exciting. We sometimes mix up workforce data with clinical data, and it's obviously not the same thing. And in allied health, we don't have any systematic allied health workforce data, and that is a separate problem. But if we can resolve both of those problems, there is this entire world that we currently can't see about primary allied health activity, clinical activity, that will help us create funding mechanisms that are much more closely attuned to what demand requires. Whereas right now we have really no read on demand of the primary allied health workforce, but we could if we had better clinical data sets that enables that interrogation.
Kath, that sounds like a research question, but maybe it's also just a routine needs question. Demographic changes in the population and different pressures from different areas means that we have to have the agility of knowing things in relatively near real time in order to respond appropriately.
It's that real time. And it's understanding that population. And also it might be, I need to upskill my clinicians. Let's upskill so we can actually provide what's required to the patient group that we're actually looking after.
That's good. I forensically listened to every episode you've produced last night while I was cooking dinner, because I was like, I don't know what I am going to say here. So I'm going to listen to all the others and go, what did they say? And then I got snippets and I was like, well, that's good. I like that. I like that.
You've done even better by actually learning stuff on the way. Wonderful.
So thank you very much for the opportunity. I really, really appreciate it.
Thanks, everyone.
Fantastic. That was a terrific chat. Thanks so much for your time.
The Sparked podcast is brought to you by the Australian Federal Department of Health and Aged Care, CSIRO's Australian eHealth Research Centre, HL7 Australia, and the Australian Digital Health Agency. You can join the community by heading to sparked.csiro.au. And don't forget to join us on LinkedIn at SparkedAU. This show is hosted by me, Brett Sutton, Director of Health and Biosecurity at CSIRO, and produced by Edge Studios' Janine Hamer and Lucy Ratz, and CSIRO's Dr. Naomi Stecklenburg. Sound by Hayley Dell.